Welcome to Part 2 of Section 3 in Neurology. In the last part of this section, we introduced the cranial nerves and had begun going through some examples. In this section, we'll continue going through important examples to tie all of the information together. Let's get started. When the patient is asked to say "ah" in an attempt to elevate the palate, the uvula deviates to the right. What cranial nerve shown below is likely damaged? Remember, the vagus nerve normally innervates the muscles of the soft palate, which helps elevate that side of the mouth and keep the uvula midline. When the vagus nerve is damaged, the ipsilateral palate can no longer be elevated, which results in unopposed elevation of the opposite side when the patient says "ah." In other words, damage to the vagus nerve results in deviation of the uvula to the opposite side. So damage to cranial nerve 10 results in contralateral deviation of the uvula. From the question stem, we can see that the patient's uvula deviates to the right, which must mean the left vagus nerve is affected. With this in mind, we need to be able to identify the vagus nerve from this anterior view of the brainstem. Because we're looking at an anterior view of the brainstem, we can deduce that this is the right side and this is the left side. In this case, we can see the left vagus nerve right here. If we look at figure 8.22 again, we can see all of the cranial nerves labeled. Again, this is figure 8.22. We can see the vagus nerve is right here. From table 8.1, we can see that the vagus nerve is responsible for elevating the soft palate and keeping the uvula midline. Okay, let's do another question. A 65-year-old female presents to the neurologist with numbness of the anterior tongue with taste intact and difficulty chewing food. The damaged nerve passes through which foramen of the skull? Okay, because this patient has numbness of the anterior part of the tongue and difficulty chewing food, we can deduce that the mandibular branch of the trigeminal nerve must be affected. So, V3. As we can see from table 8.1 from your text, the mandibular branch of the trigeminal nerve is responsible for sensation around the mandibles, sensation of the anterior two-thirds of the tongue, as well as muscles of mastication. It's important to remember that taste of the anterior part of the tongue is innervated by the facial nerve and not the mandibular branch of the trigeminal nerve. Again, this is sensation of the anterior two-thirds of the tongue, but not taste. From figure 8.23, we can see that the mandibular branch of the trigeminal nerve passes through the foramen ovale. So this region right here. So again, from the question stem, we should notice that sensation from the anterior tongue is damaged and that the patient has difficulty chewing food. Both of these symptoms should make us think of damage to the mandibular branch of the trigeminal nerve. And then we need to recall that this nerve traverses the foramen ovale. Okay, let's do another question. A patient presents with deviation of the left eye toward the midline when asked to look straight ahead. The neurologist suspects a tumor compressing which region of the brain? So the right eye is not mentioned, so we can assume it's unaffected. But the left eye deviates medially, like this. Again, right eye is unaffected. Recall that the abducens nerve innervates the lateral rectus muscle, which is responsible for moving the eye laterally. If the abducens nerve is damaged, then the medial movement of the eye is no longer counterbalanced by the force of the lateral rectus, so the eye will tend to move medially. So in this case, the lateral rectus is affected, which means the abducens nerve must be affected, which again is cranial nerve 6. And recall that cranial nerves 5 through 8 emanate from the pons. In this case, we're asked which region of the brain is being compressed by a tumor, so the answer is the pons. From table 8.1, we can see that the abducens nerve normally provides motor output to the lateral rectus. Okay, let's do another question. A newborn has a cleft upper lip secondary to Patau syndrome. The nerve that innervates this region passes through which foramen of the skull? It's not particularly pertinent to get this question right, but recall that Patau syndrome is a disorder caused by an extra chromosome 13. So trisomy 13. And this results in several abnormalities, including a cleft lip. In order to get this question right, we need to remember what nerve innervates the upper lip. Remember, the upper lip is innervated by the maxillary branch of the trigeminal nerve. From table 8.1, we can see that the maxillary branch of the trigeminal nerve provides facial sensation around the maxilla. And this would include the upper lip. From figure 8.23, we can see that the maxillary branch of the trigeminal nerve passes through the foramen rotundum. Okay, let's do another question. When a patient is asked to look to the left eye moves laterally and the right eye moves medially and slightly superior. What part of the brainstem is likely involved? Okay, let's draw this out to see what's happening. This will represent the patient's right eye, and this will represent the patient's left eye. From the question stem, we can see that when looking left, the left eye moves laterally. So let's show that here. When looking left, the left eye moves laterally. The right eye moves medially, as expected, but also slightly superior, which is unexpected. So like this. These clinical findings should make you think of damage to the trochlear nerve. Recall that normally the trochlear nerve innervates the superior oblique muscle. If we draw an eye that's normal over here, we can see that the superior oblique muscle normally inserts on the eye at an angle like this. It can be somewhat difficult to visualize, but this muscle normally causes the eye to move downward like this, as well as intort or internally rotate like this. This means when the trochlear nerve is damaged, the eye has a difficult time moving downward and internally rotating. This is also why when the patient is asked to look to the left, the right eye moves slightly upward. Normally the eye movement is balanced by muscles pulling upward and downward, so a loss of the superior oblique muscle will result in an excessive upward force. Examiners commonly like to mention that the patient has difficulty going downstairs or reading because these actions commonly involve looking down. Okay, so we know that the trochlear nerve is damaged, but the question is asking what part of the brainstem is likely involved. In order to get this question right, we need to recall that cranial nerves 3 and 4 emanate from the midbrain. So in this case, the midbrain is likely involved. Again, this is table 8.1 from your text, which tells us that the trochlear nerve provides motor output to the superior oblique muscle. Okay, here's another question. How would damage to the facial nerve alter hearing? Recall that the facial nerve normally innervates the stapedius muscle, which helps stabilize the stapes bone. In other words, the facial nerve innervates the stapedius muscle, which dampens sound. So the facial nerve normally innervates the stapedius muscle, which dampens sound. When de-innervated, the stapedius muscle loses its control on the stapes bone such that the bone can oscillate more forcefully, causing the patient to experience sensitivity to sound or hyperacusis. As we can see, damage to the facial nerve would result in hypersensitivity to sound. From table 8.1, we can see that the facial nerve is normally involved in modulating sound. And again, that is through the stapedius muscle. Okay, let's do another question. An MRI shows a fracture of the right hypoglossal canal. What symptoms would be present in the patient? Recall that the hypoglossal nerve traverses the hypoglossal canal. Damage to this nerve results in ipsilateral tongue deviation. Normally, the muscles innervated by the hypoglossal nerve help stick the tongue out like this. So here's the tongue. They normally help the tongue move out like this. In this question, the right hypoglossal nerve is damaged, which means the right side of the tongue is paralyzed. Right, left, right is paralyzed. This means the actions of the muscles on the left side of the tongue are unopposed, which will cause the tongue to deviate to the right. Some students use the mnemonic, "the tongue licks the wound," to help them remember that when the hypoglossal nerve is damaged, the tongue deviates to the same side that was damaged. Again, from table 8.1, we can see that the hypoglossal nerve is normally responsible for moving the tongue. From figure 8.23, we can see that the hypoglossal nerve normally traverses the hypoglossal canal. Okay, let's do another question. 1 month ago, a 23-year-old male developed a ring-like rash after hiking in the Appalachian Mountains. He presents to the emergency department today due to complete paralysis of the right side of his face. What region of the brain is likely involved? From the question stem, hopefully you picked up on the fact that this patient has Lyme disease. Recall that Lyme disease is caused by a microbe called Borrelia burgdorferi, which is commonly transmitted by the Ixodes deer tick, which is prevalent in the northeastern United States. Stage 1 of Lyme disease commonly results in a ring-like rash. This rash is called erythema migrans, which our patient had after hiking through the Appalachian Mountains. Stage 2 of Lyme disease can result in facial nerve palsy. For step 1, it's important to know that Lyme disease results in damage to the lower motor neuron of the facial nerve, which results in complete paralysis of the ipsilateral face. Let's draw this out again to remind you of the unique neural pathway of the facial nerve. This will represent the facial nucleus in the pons, which contains an upper component, so U for upper, and lower component, L for lower. The upper component receives innervation from both cerebral cortices, whereas the lower component only receives innervation from the contralateral cortex. Let's draw this out. So again, as you can see from this image we've just drawn, the upper component receives dual innervation, whereas the lower component only receives innervation from the contralateral cortex. It's important to know that the upper component of the facial nucleus innervates the superior aspect of the face. So this will represent the face, and the upper component innervates the upper face, whereas the lower component innervates the lower face. So again, Lyme disease results in damage to the lower motor neuron of the facial nerve, which means both the upper and lower components of the facial nucleus would be damaged. As we can see from this pathway, damage to the right facial nucleus would result in complete paralysis of the right side of the face. This is figure 8.25 for your review, which illustrates the facial nerve pathway we just discussed. So again, the question is asking about what region of the brain is likely involved. As I just showed, the facial nucleus is damaged due to Lyme disease, which means the pons must be involved. Recall that cranial nerves 5 through 8 emanate from the pons, so in this case we can assume that the pons must be involved. Okay, let's do one more question. A 26-year-old male presents to the emergency department after an automobile accident. Upon examination, the physician notices several abnormalities of the right eye, including ptosis, mydriasis, and an inability to look to the left. What foramen of the skull was likely fractured? From the symptoms provided, we should be able to deduce that the patient has damaged cranial nerve 3, or the oculomotor nerve. From table 8.1, we can see that damage to the oculomotor nerve would result in ptosis or drooping of the eyelid, because the oculomotor nerve normally assists with eyelid elevation. We'd also expect the right pupil to be dilated or to experience mydriasis, because the oculomotor nerve normally causes pupillary constriction. Finally, we'd expect the patient to be unable to look medially because the medial rectus is damaged. So again, from the question stem, we can see that the patient has abnormalities affecting the right eye, including ptosis, mydriasis, and an inability to look to the left, which should make us think of damage to the oculomotor nerve. From figure 8.23, we can see that the third cranial nerve traverses the superior orbital fissure. So the right superior orbital fissure was likely fractured, resulting in damage to the right third cranial nerve. So again, this patient has ptosis, mydriasis, and an inability to look to the left. This is all occurring in the right eye, which should make us think of damage to the right oculomotor nerve. So cranial nerve 3, and again this nerve traverses the superior orbital fissure.